So I'm Dr. Susie Shapiro. I'm one of the consultant haematologists in Oxford, and thank you to Emma McGee and Joe Jerome from Thrombosis UK for asking me to speak today. So I'm going to go through COVID-19 thrombosis and VTE prevention. In general, I'm going to talk about before COVID, what we used to do with inpatients, extended thromboprophylaxis on discharge and community. And then I kind of want to talk about what's changed, including our thinking and how it's evolved over the last 18 months or so with COVID, looking at the thrombosis risk with COVID, how we've tried to quantify that, and then the strategies to reduce the thrombosis risk in the different groups of patients. So before COVID, what did we do? Well, you know, we were relatively happy. Medical and surgical patients we know have an increased risk of VTE. Going back to Virchow's triad, they have increased sticky blood through infection or inflammation. There's often reduced blood flow because of immobility in the hospital, and potentially injury to the vessel wall, either through surgery or inflammation can also cause injury to the vessel wall. And we know that low molecular weight heparin standard thromboprophylaxis reduces risk in these inpatients. It reduces risk in medical inpatients by approximately 50%, and in surgical patients as well. So in hip and knee arthroplasty, it reduces the risk by about 80%. Post-discharge, we standardly give extended thromboprophylaxis following specific surgery, so hip and knee arthroplasty, major abdominal cancer surgery, but we don't standardly give it to medical patients on discharge. And there have been a lot of trials of extended thromboprophylaxis in medical inpatients. So I've listed the 5 main trials here, and you can see, so the first one, Acclaim, that used enoxaparin, a low molecular weight heparin, for 28 days. And the others have used different DOACs, so apixaban and rivaroxaban. Betrixaban, which is not licensed in the UK, but was for a while in the United States, and rivaroxaban again. And they've kind of looked at 30 to 40 days following discharge. A meta-analysis of these trials shows that it does work. Overall, if you extend thromboprophylaxis out to about 35-40 days, you will reduce the risk of VTE or death from VTE by about 40%, but you double the risk of major or fatal bleeding. So actually, the balance is relatively fine. So the number to treat for to prevent one symptomatic VTE or VTE death is 250, with the number needed to harm with one major or fatal bleeding event of 333. So that's why we're not routinely currently giving it to medical inpatients. And ideally, you would find those medical inpatients on discharge who have the highest risk of VTE, and then that they would potentially be considered for it. The other group of patients is outpatients, and you know, VTE prevention in the UK has concentrated initially on the inpatients, which is the highest risk group, and more we're thinking, well, actually, what about the community patients? What should we be doing for them? Partly also because within that, hospital care is starting to move more ambulatory. So as part of the NHS 5-year plan, there's a big drive for same-day emergency care and ambulating patients or acute hospital at home. What is their VTE risk? How should we be risk assessing them? Should they be having, or should a subgroup of them at particularly high risk of VTE be getting thromboprophylaxis? And we don't really know, and that's an area in general for more research. So then COVID-19, and it does increase the risk of blood clotting. There was and there still is a vast number of studies. They started coming out very quickly. And by September 2020, this was an analysis of the studies by September 2020, which looked at 66 studies with more than 28,000 patients. And overall, the risk of VTE with COVID was found to be 14%. But if you're once on ICU, then the risk is higher, it's about 20%. Within that, the risk of PE appears to be higher than the risk of DVT. is a mix as well. You can see that the studies are quite discrepant, and I think a lot of that depends on the size of the studies, whether they used additional screening strategies for looking at VTE, and the proportion of patients between ICU and ward as well. So why does it seem to be particularly sticky? I think these patients are often really unwell. The hypoxia, combined with other things, will drive a prothrombotic response. You get platelet activation, the endothelial cells get activated, you get a sepsis-associated coagulopathy. So you have the systemic hypercoagulability combined with stasis and immobility by being in bed, and endothelial damage. So we're pretty sure now that COVID does significantly increase the risk of COVID beyond what we would normally expect. So how should we be reducing that risk? Should we be increasing pharmacological thromboprophylaxis? Well, we could do that by going to intermediate dose low molecular weight heparin or therapeutic dose low molecular weight heparin. So what do I mean by intermediate dose? Well, there isn't a clear-cut standard, so different people have done different things. But for an example, deltaparin is low molecular weight heparin for a 75 kilogram person. The standard dose is 5,000 units once a day as standard thromboprophylaxis. We could double that and give it twice a day, so 5,000 units twice a day is an intermediate dose. And a therapeutic dose is 15,000 units once a day. So the standard and the therapeutic doses are well described and have been done in clinical trials. That intermediate dose is made up, but it's kind of in the middle of them. Might it be beneficial? Also, other than changing the dose of thromboprophylaxis, maybe we should be extending it post-discharge, and maybe we should be giving it to those non-hospitalized patients, because we know a lot of patients who initially present with COVID to the hospital have a PE at the time of presentation. But if we give more thromboprophylaxis, will it reduce the risk of VTE? And then what is the balance with the increased risk of bleeding? So to start with, inpatient thromboprophylaxis, and this has been a phenomenal area for randomized controlled trials. And I have tried to summarize them here. So the trials that I have listed here, some of them have been published already in peer-reviewed journals. Some of them are currently only online or have kind of been published online but not yet peer-reviewed. Okay, so it is a mixture. I've divided it into different cohorts of patients. So the ICU patients that we know that are particularly high risk of thrombosis, ward patients, and then trials which have looked at a mixed cohort. So these are all RCT, randomized controlled trials. So this top line are trials that use therapeutic anticoagulation compared to either standard dose or standard of care. And because of the concern of thrombosis early on in the pandemic, many hospitals increased standard thromboprophylaxis before the randomized controlled trials. So at the time of these REMAP-CAP platform trials, actually the standard of care in many hospitals was no longer standard dose thromboprophylaxis, but was potentially an intermediate dose thromboprophylaxis, okay? So the control group is a bit mixed. I've done red and green color coordination, sorry, which I should have explained earlier. So basically the green ones are when the intervention has shown benefit. The red ones are where it either hasn't shown benefit or it's shown harm. So you can see that it's mixed. So for therapeutic anticoagulation on ICU, the REMAP-CAP trial showed that overall it wasn't of benefit. It increased the bleeding rate and it didn't significantly improve survival. Whereas on the ward patients, therapeutic anticoagulation had a benefit. So the other thing that I need to stress is we're used to doing VTE trials and looking at kind of interventions that reduce the risk of VTE and looking at the bleeding risk. in order to get these trials underway, they were incorporated into studies that were already going. So in fact, the primary endpoints for the REMAP-CAP platform trials and for many of the others are actually not reduction in VTE compared to bleeding, but overall survival or a need for organ support. So it's different to what we're looking at in the VTE world. So the REMAP-CAP study that showed benefit in the ward patients showed if you had therapeutic anticoagulation, you had a 4% less chance of needing kind of escalating organ support whilst you were in hospital before discharge. It did slightly reduce the risk of VTE, but it also increased the bleeding risk. But the positive primary endpoint was actually a reduction in needing organ support. The other trial that I want to concentrate on is Inspiration, which is looked at intermediate dose against standard dose low molecular weight heparin on the wards. So what I'm going to do is I'm just going to talk in a bit more detail quickly about the REMAP-CAP trial on the ward and the Inspiration trial on ICU. But overall, if you try and remember that slide with the red and the green, that is why your hospitals at the moment will likely be doing a mixture of interventions, because despite these RCTs being underway and publishing results, it remains slightly unclear what the best management is in different patient cohorts. Okay, so the REMAP-CAP I've already talked about just on the other slide, but just to recap, a randomized controlled trial in moderately severe COVID patients hospitalized on oxygen, but not initially on ICU. They were randomized to therapeutic anticoagulation with low molecular weight heparin or heparin against the usual standard of care, which was a mixture of standard dose or intermediate dose. Huge numbers of patients were screened, about 13,000 patients. 7,000 didn't meet inclusion criteria. 1,244 patients were randomized into this moderately severe arm, which I'm going to concentrate, but approximately another 1,200 were randomized into the ICU arm. And this is the kind of information that we got from it. So looking at the top, the blue bars and the blue line are the usual standard of care thromboprophylaxis, and the orangey red color is the therapeutic dose anticoagulation. And here they've kind of tried to do it looking at the proportion of patients between the therapeutic dose anticoagulation and usual standard of care, and looking at the organ support for 3 days. So those on therapeutic anticoagulation had an increased 4%, were 4% less likely to not need organ support, which was their positive primary outcome. But here you can see the major bleeding was increased from usual care of 0.9% to therapeutic dose anticoagulation of 1.9% major bleeding. But that trial, the reason I've concentrated on that is that trial will have changed practice in many hospitals, but not all hospitals, for ward patients to be considered for 14 days of therapeutic anticoagulation. The Inspiration trial, I think, is really interesting because it's been published a while ago, and I don't think it's really seeped back into practice. So again, because of the concerns at the start of the trial, many hospitals, particularly on ICU, increased standard thromboprophylaxis to actually be an intermediate dose low molecular weight heparin. And the Inspiration trial was published in April. It was a randomized controlled trial of 562 patients on ICU. And they looked at 30-day outcomes following either a standard dose prophylactic low molecular weight heparin or an intermediate dose. And an intermediate dose did not improve the primary outcome, which was a composite of the death where the treatment with ECMO was needed and thrombosis, but it did increase the risk of major bleeding from 1.4% to 2.5%. So that suggests that intermediate dose low molecular weight heparin is not advantageous above standard dose low molecular weight heparin in ICU patients with COVID. So overall, looking at these trials, I think what we can take out of it is on ICU, we should not be using therapeutic anticoagulation unless there's a definite other indication, such as someone that has atrial fibrillation. And we know that because of the REMAP-CAP platform trial on ICU. Intermediate dose has not been shown to be of benefit over standard dose prophylaxis. We know that from the Inspiration trial that I've just shown. And there's no clear benefit of additional antiplatelet agents. So that's from a REMAP-CAP press release. And we're still waiting for the full data of that. For the ward patients, based on the REMAP-CAP platform trial that I went through, we should be considering at least therapeutic anticoagulation with low molecular weight heparin as a way to reduce the need for escalating to organ support, but use low molecular weight heparin rather than rivaroxaban, which was shown in another randomized controlled trial not to be of overall benefit. Other trials, such as the RAPID, actually fell on the slide of giving standard dose low molecular weight heparin prophylaxis compared to more. And the recovery trial showed that aspirin doesn't have an additional overall benefit. Again, that's in preprint rather than a final published report. So really, standard dose thromboprophylaxis, which we've always done, is pretty good, but we should be considering therapeutic in the wards, but not on the ICU patients. So how about post-discharge? Based on those 5 trials and the meta-analysis that I showed you right at the beginning for extended thromboprophylaxis in medical inpatients, at the beginning of the pandemic, the American College of Chest Physicians released guidelines with their own analysis based on that data that said that actually with COVID, if the risk of symptomatic VTE is more than 1.8% at 35 to 48 days after discharge, then there would be a net benefit of extended thromboprophylaxis in patients with low-risk bleeding. So then based on that analysis, the question is, post-discharge, following hospitalization with COVID, is the risk of symptomatic VTE more than 1.8%? So King's did a very good data analysis quite early on in the pandemic of a huge number of patients. They looked at 1,877 medical patients discharged following COVID near the start of the pandemic, and they weren't given any post-discharge thromboprophylaxis. And they found that the incidence of VTE was 0.48% at 42 days post-discharge, so well under that 1.8%. Which suggests that we shouldn't be giving any extended thromboprophylaxis for these patients. And they found that that post-discharge rate wasn't particularly higher than their usual, which again is really reassuring. The only thing is, we don't know the specifics of all of those patients and how many were on anticoagulation. So if you want to look more at this, or we decided locally to find out about our own cohort of patients and look at some of the specifics of them. So it's a much smaller study. There was a case control cohort of 300 odd patients. And then we did a sub-analysis of the 157 patients who were discharged without an indication for anticoagulation, because it's only that subgroup that we would be considering extended thromboprophylaxis for in these circumstances. So at the time, these 157 patients who had been admitted with COVID and then discharged without indication, the vast majority, 97% of them, weren't given any discharge thromboprophylaxis. And we had a symptomatic image confirmed VTE rate of 2.6% at 42 days, so slightly higher than that 1.8%. So based on our local data, actually it suggests that maybe this group of patients that we were seeing should be having extended thromboprophylaxis, but the numbers are small. So I still think that that is a bit grey. And there are randomized controlled trials. Unfortunately, it's going to be about another year until the biggest one's going to complete. So it may be great until then. I think we just need to keep on collecting our data and particularly looking at our own local cohorts of patients. And finally, I just want to touch on people with COVID not requiring inpatient treatment, because this in general is an expanding area, but it's particularly expanding with COVID and ambulatory care. And it really falls into two groups of patients. There's the COVID virtual ward patients from hospital-led virtual wards, which I'll describe in more detail in a moment. And then there's the community patients, you know, and I think the thing about this group is it's a particularly wide spectrum, because, you know, people may be asymptomatic in the community to really quite unwell and just not quite wanting to go to hospital, and then all the individual characteristics of those patients. So I had thought a few months ago that this might all be resolved, because there was a tweet with a study of 220,000 patients, which found no increase in non-hospital VTE in patients with COVID. And I thought, great, sorted. But actually, as is often the case when you go into it, it's not quite that simple. So I know the slide is really busy, so don't worry too much. It's just to remind me. Basically, of the patients who had, they looked at people who had had COVID testing generally in the community. Some were positive, some were negative, and they looked to see who got a VTE afterwards. Of the patients who had a positive COVID swab and got a VTE, it was actually a really mixed COVID. So only 60% of them had actually been tested in an outpatient setting for COVID. And of those, 76% required subsequent hospitalization, and there's no details around the thromboprophylaxis and anticoagulation. So it was a very mixed group. Many of the patients were actually tested in hospital, and so it's difficult really to know what to conclude from that. So with regards to the community in general, I still don't know. Many of us will be faced with starting hospital-led virtual COVID wards. And so I'm just going to discuss what we did in our early data from that. So what I mean by a hospital-led COVID virtual ward is we currently have set up a service where patients are reviewed in ED and AAU. They're considered well enough to go home with COVID, but there's just a concern that they're at risk of deterioration, which can be that they've got one or more known risk factors for deteriorating with COVID, or just that kind of feeling of clinical concern. And about November last year, we set up this virtual ward for these patients. So they're sent home with an oxygen saturations probe. And because we had to decide what to do for thromboprophylaxis, and there were no guidelines at the time, we decided to give them 7 days of prophylactic low molecular weight heparin unless they were at high bleeding risk, because we thought that these patients were quite borderline for needing admission. And we knew that COVID was sticky blood, and we thought, well, let's do 7 days with low molecular weight heparin. If they really can't self-inject, then with 10 milligrams of rivaroxaban. And actually, after we started this COVID ward, the NICE guidelines came out, which has suggested that you should be considering low molecular weight heparin in this group of patients. The patients get a daily phone call for 14 days and at 6 weeks. Now, the patients were actually really quite sick. So we had quite a high rate of either patients needing to come back in for being reassessed, or subsequently then needing to come back in for readmission. But on an intention to treat analysis at 42 days, we had 2 VTEs. One was diagnosed with PEs within 36 hours of the initial referral. And actually, so I don't think it would have been preventable by the thromboprophylaxis that we started. It was possibly a delayed diagnosis. Interestingly, one was diagnosed with a below knee DVT at 17 days post initial presentation, but by that stage was feeling much better. And so the patient opted for serial scanning rather than anticoagulation, and the clot didn't extend. So really, in a group of 145 patients that I thought were pretty sick with COVID, that is quite a low VTE rate. The bleeding rate with low molecular weight heparin was reasonable. So there were no major bleeds. There was one patient who temporarily stopped thromboprophylaxis for a nosebleed. There were quite a lot of minor bleeds, but it tended to be nose bleeding following COVID swabs that was very, very minor. So That data, I suppose, is relatively reassuring for us locally, that probably that 7 days is reasonable, and that we'll keep on going until more randomized controlled data comes out. Again, there are RCTs underway. They may be completed relatively soon, but we'll have to see whether those completion dates kind of for September or so this year kind of hold. So the NICE guidelines, as a kind of a summary slide, there is very good COVID guidance, which is living guidance, and it's updated very regularly. So currently for inpatients, it says offer weight adjusted standard dose low molecular weight heparin for a minimum of 7 days. So that is what we are all being advised to do. We can then consider treatment dose low molecular weight heparin for 14 days or until discharge, which is what the REMAP-CAP trial did, in patients who need low flow oxygen, are on the wards, but dose reduction may be needed if circumstances change. In a research setting only, offer intermediate dose or treatment dose low molecular weight heparin for patients on ICU. The extended VTE thromboprophylaxis on discharge, it doesn't really say, it just says this inpatient prophylaxis should be a minimum of 7 days and to be continued if the patient is discharged after a shorter duration. And for the community, it says for hospital-led acute care, I guess such as our virtual ward clinic, consider thromboprophylaxis, balancing the risk against benefit. So, you know, that balancing act between doing what we know works pre-COVID in patients with COVID, trying to balance the increased risk of thrombosis with bleeding is really challenging. We know a huge amount more than we did 18 months ago, but we've still got an awful lot to learn, I think. So thank you very much. And I'll stop screen sharing.
Thank you so much, Susie. Such a lot of information there. Really, really interesting. And I think it really helps to clarify some of the confusion with all of the data from so many RCTs. It's a bit of a minefield. So thanks very much for laying that out really clearly. I guess I'm hoping that we've got lots of clinical ward staff listening today. Is there anything that ward staff can do to help reduce the risk of thrombosis in their patients that have quite severe COVID, other than giving the thromboprophylaxis that's prescribed?
Well, that's a really good question, Emma. So all the things that I guess ideally we would be doing generally are really good to do. So partly, I think, depending how unwell the patient is, it's explaining everything to them. Maintaining good hydration, trying to mobilize as much as possible. All of that will help. And I think, you know, in general, we're all shattered at the moment, aren't we? And staffing is low and mistakes will happen. So every member of the team acting as a safety net. It's easy for someone to forget to prescribe thromboprophylaxis. It's easy, given all the changes in intermediate dose, therapeutic dose, to get in a bit of a muddle and for the wrong thing to be prescribed. And so I just think everyone trying to act as a safety net, if you're not sure that the patient has been prescribed the right thing, or maybe the patient's circumstances have changed and you're worried about bleeding, then flag it up and don't hesitate to flag it up.
I think that's such good advice and so important, particularly at a time where the guidelines have been quite dynamic themselves as well. Like I say, it can lead to confusion. We talked a little bit at the outset of your talk, you talked a little bit about the processes involved in thrombosis that's linked to COVID. And it can be a little bit different, can't it, from your standard, particularly the PE that originates in the lungs in COVID, rather than the embolization that we would often see. How have you found that patients with COVID and PEs have done? How have they recovered from their PEs? Have they had many long-term side effects? it's always difficult because obviously they've got respiratory symptoms with COVID. So how have they done longer term?
Yes, that's really interesting. So actually, so two things. So I'll come back to that exact question in a moment, but it did remind me because I can quite fit in everything that I thought about discussing. So with the PEs that are increased in COVID, there's a mixture of what look to be like big lobar PEs and these smaller subsegmental PEs. And the smaller subsegmental ones, the thinking is that actually it's immunothrombosis. So rather than having that standard DVT that you described that goes to the lung, that actually you're having in situ thrombosis because of the local inflammation. So we don't really know. Well, we didn't, thromboprophylaxis we don't normally give for that. So how effective is it at reducing that immunothrombosis is one of the things that needs to be taken into account as we kind of change the standard thromboprophylaxis that we do. But with regards to how they do, so we get referred all patients who have had a VTE for review at 3 months, which is our standard time to review it. And it's been really interesting seeing people who have had PEs because of COVID. So it's really mixed. But I think compared to most PEs, we probably have a slightly higher proportion who are still feeling short of breath at 3 months. And so whether that is the PE or whether that is lung damage from COVID, it's difficult to tease out. So actually we've started seeing, if we're referred to someone with a COVID associated PE, we've started pushing it back from 3 months to closer to 6 months, just to give them longer to recover from the COVID and the breathing to come back to normal. But overall, the outcomes are really good. And I've seen people who have had a torrid time being on ICU, developed PEs, horrendous, but actually at 6 months, although they're still shattered, and kind of exhausted, their breathing is pretty much back to its baseline.
No, thank you. That's really useful. And I guess coming back to my question about the role of ward staff as well, the jury's still a little bit out, but it seems like patients that have COVID in the community or have been hospitalised may be at increased risk of more than most hospitalised patients of having a blood clot once they leave hospital. So I guess patient information, like you already suggested, is going to be key, isn't it? Letting patients know signs and symptoms and what to do if they experience any, so that at least early detection may actually prevent any sort of serious illness from VTE.
Yeah, absolutely. I think that's really important. And I know patients are overwhelmed when they come in, and then there's more information on discharge. But yeah, I think trying to remind them of the risk of VTE and giving them any local patient information leaflets is really beneficial.
That's wonderful. Thank you so much for joining us today, Susie. Really appreciate it.
Thank you both very much. It's a pleasure.